see about the drugs used in the management of tuberculosis. In the next class, we will deal with the pharmacotherapeutic regimen used in the management of tuberculosis. Today we will just see what are all the drugs which are used in the management of tuberculosis. As you all know, tuberculosis is a chronic infectious disease caused by Mycobacterium tuberculosis, and it usually affects lungs. Okay, but almost all organs can be affected by tuberculosis. Okay, sparing very few organs like skeletal muscles, something like that. But this disease can affect any organ of the body, but most commonly it affects lungs. If you look into the epidemiology, actually 1/3 of the Indians are actually harboring the pathogen, and it causes millions of deaths worldwide annually. If we talk about the major symptoms of tuberculosis, by this time you should know all the major cardinal symptoms of tuberculosis, but sometimes one or two may be missing. So clinical suspicion should always test for the presence of tuberculosis. Okay, so major symptoms includes fever, cough with hemoptysis, loss of weight and loss of appetite over the period of 2 weeks. Okay, if all these symptoms present over the period of 2 weeks, then we need to suspect tuberculosis. So one of the foremost diagnostic procedure to diagnose tuberculosis, especially of pulmonary origin, is the acid-fast bacillus staining of the sputum. Okay, so you can see that characteristic pinkish red bacilli being stained with acid-fast bacilli in the blue background. Okay. And the other diagnostic modality, the most common, or no, I will not say the most common, the other common diagnostic modality is X-ray. You can clearly see the various infiltrates. So you can see the various infiltrates which are characteristic of tuberculosis. Okay. Now, the thing is, tuberculosis has an entirely different set of antibiotics, and the usual antibiotics which you learned until now do not work properly in the management of tuberculosis. There are reasons for that. First of all, the cell wall is made of a special lipid called mycolic acid, which is absent in almost other class of bacteria. It's present only in Mycobacteria. Then the amount of efflux pumps are really high in Mycobacterium tuberculosis. It is actually, efflux pumps are present in other bacteria also, but the relative abundance of efflux pumps is more in Mycobacterium tuberculosis. You can see that this efflux pumps are usually ATP binding cassette permeases, and it can comprise almost 2.5% of the genome. Then not only that, bacilli usually are intracellular, especially they are present inside the macrophages. So it is difficult to target the bacilli. And of course, antibiotics usually work on dividing cells better, and since the Mycobacterium tuberculosis has a very slow growth, so we need to have some antibiotics which can act on non-dividing cells also. Okay, so just remember this slide. This at the end of this class, at least you should be able to answer this slide. Okay. First line anti-tuberculosis drugs. Isoniazid, abbreviated as H. Rifampin, abbreviated as R. Pyrazinamide, abbreviated as Z. Ethambutol, abbreviated as E, and streptomycin, abbreviated as S. So HRZES. Isoniazid, rifampin, pyrazinamide, ethambutol, and streptomycin. There are various second line drugs. If the first line drugs fail to manage tuberculosis, or if the bacillus develops resistance against first line drugs, then we will have to use second line drugs. The second line drugs are kanamycin, fluoroquinolones like levofloxacin, moxifloxacin. Then we have ethionamide, cyclosidin, capreomycin, linezolid, para-aminosalicylic acid, clofazimine, and amoxicillin clavulanic acid. Okay. Of course, second line drugs are actually less efficacious when compared to the first line drugs, and the duration of treatment is much longer for the second line drugs when compared to the first line drugs. When we talk about the mechanism of action of various first line drugs, you can see that the first line drugs target various bacilli. Okay. So there are drugs which can target the nucleic acid, there are drugs which targets the formation of cell wall and cell membrane, and there are drugs which can target the ATP synthase, okay, the last part of the respiratory chain. Okay, so we shall see the drugs one by one. First, we will see about rifampin. It's a drug which enters the bacilli in a concentration dependent manner, and it binds to the beta subunit of DNA dependent RNA polymerase. Basically, it blocks the enzyme which synthesizes RNA. Okay, so from biochemistry you should understand the function of enzymes from the names only. So RNA polymerase is an enzyme which will help in the synthesis of RNA. So rifampin binds to the beta subunit of DNA dependent RNA polymerase enzyme. So rifampin is actually bactericidal against Mycobacterium tuberculosis and other mycobacteria of Mycobacterium tuberculosis complex, including Mycobacterium bovis and africanum. Minimum inhibitory concentration ranges from 0.03 to 0.125 microgram per ml or milligram per liter. So rifampin actually affects most gram-positive bacteria as well as gram-negative microorganisms, not only Mycobacterium tuberculosis. But to prevent the development of resistance to rifampin, we do not use rifampin in the management of other infections. Okay, because the pharmacotherapy of Mycobacterium tuberculosis lasts for months, whereas for other diseases it lasts for weeks. Okay, so if we just give rifampin for only a few weeks and stop it, and as we already saw that Indians, 1/3 of the Indians harbor Mycobacterium tuberculosis, that will easily lead to the development of resistance to rifampin for Mycobacterium tuberculosis. It may be sensitive to other organisms, but it will Mycobacterium will develop resistance against rifampin. When no other drugs are present for managing MRSA, then rifampin can be used. Rifampin is also very efficacious against meningococcus, and the post-antibiotic effect of rifampin is present, and which is concentration dependent. Rifampin resistance, as you all saw in the general characteristics of antibiotics, usually there are various ways the resistance might develop against the bacterium. So one is the mutation of the target. Okay, so here a resistance to rifampin develops when the beta subunit of DNA dependent RNA polymerase mutates and fails to bind to the drug. If we talk about the pharmacokinetics, we all know that the pharmacotherapy of tuberculosis is really long, and oral drugs are actually preferred when compared to injectables. Okay, so almost all first line drugs of tuberculosis are administered orally except aminoglycosides. Aminoglycosides is always administered as intramuscular injections or as intravenous infusions. Okay, it cannot be administered orally. But rifampin can be given orally and it's very well absorbed. The P glycoprotein lowers CNS penetration, but still it's not a big problem in the management of CNS infections or CNS tuberculosis infections. It causes autoinduction of its own metabolism by inducing CYP3A enzymes, and the half-life of rifampin is around 3 to 5 hours. Rifampin is metabolized in liver and excreted in feces. 1/3 of the drug is excreted in urine. When we talk about the measurement of the pharmacodynamic character of rifampin, the bactericidal effect is usually measured as AUC by MIC. AUC stands for area under curve of rifampin, and MIC stands for minimal inhibitory concentration of rifampin against the Mycobacterium tuberculosis isolate from the particular person. MIC will vary from person to person, and the AUC will also vary from person to person. But the resistance is predicted with Cmax by MIC. Cmax is nothing but the maximum concentration attained after the oral administration. Rifampin uses, of course, we are dealing with the drugs used in the management of tuberculosis. Of course, rifampin is used in the management of tuberculosis. Apart from that, it is also used in the prophylaxis of meningococcal disease and H. influenzae meningitis. The dosage is around 600 mg twice daily for 2 days or 600 mg once daily for 4 days. When we talk about the adverse drug reactions of rifampin, it's a relatively safe drug. We have rash, fever, nausea and vomiting, common side effects. One of the characteristic side effect is the harmless change of color of urine. The urine appears orangish, sometimes it is mistaken for blood in the urine. So you should always advise the patient not to panic when they see orange urine during the pharmacotherapy of tuberculosis. Even though it's due to the color of the metabolite and it is very harmless. In high dose, it might cause flu-like syndrome, which consists of fever, chills and myalgias, and it occurs in 20% of the patients treated. Again, it's not very dangerous. The syndrome may include eosinophilia, interstitial nephritis, acute tubular necrosis, thrombocytopenia, hemolytic anemia and shock. So these type of extreme symptoms occur, then we have to stop the drug. As we already saw that the drug is metabolized by CYP3A enzymes and it also auto-induces, because rifampicin is a drug inducer and it is more prone for drug interactions, especially when the other drugs is metabolized by various enzymes such as 1A2, 2C9, 2C19 and 3A4. The next drug we are going to discuss is pyrazinamide. It is the synthetic pyrazine analog of nicotinamide. When we talk about the mechanism of action, it's a little complicated and elaborate, but still it's easy to understand. Okay, let's say this is the cell wall of Mycobacterium tuberculosis. When pyrazinamide is administered orally, it crosses the cell wall. Okay. Inside the cell wall, with the help of pyrazinamide is converted to pyrazinoic acid, and this pyrazinoic acid is pumped out of the cell wall by an efflux pump, and this pyrazinoic acid is protonated outside the cell wall, which again enters the cell wall. This protonated POA, or which is also called as POAH, finally inhibits the fatty acid synthesis by targeting the enzyme fatty acid synthase, and thereby affecting the formation of cell membrane. So inhibition of fatty acid synthase type 1 leads to the interference with the cell membrane formation, and that is, it also causes the damage in Mycobacterium tuberculosis by reducing the intracellular pH and by the disruption of membrane transport. Of course, as we all can predict, resistance to pyrazinamide is caused by alteration in the pyrazinamidase enzyme. When we talk about the pharmacokinetics of pyrazinamide, it's well absorbed orally, it's metabolized in liver and excreted in kidneys, and so renal failure will recover dose alteration. The Tmax is around 2 hours and half-life is around 8 to 11 hours. The pharmacodynamic characteristics of pyrazinamide is usually measured as AUC by MIC efficacy, and the resistance is measured by time greater than MIC. Uses of pyrazinamide is used in the management of Mycobacterium tuberculosis. Otherwise, it does not have any other use. And the major adverse drug reaction is liver damage. The next is we have isoniazid I. So we have this drug isoniazid. When it enters the bacillus, okay, it is activated by CATG enzyme as a nicotinoyl radical, which then spontaneously combines with NAD plus or NADP plus, forming nicotinoyl NAD adduct or nicotinoyl NADP adduct. Basically, they block this INHA enzyme and dihydrofolate reductase, thereby the final result will be the inhibition of mycolic acid synthesis and thereby affecting the cell wall formation. For the drugs which are not entering the bacillus, here the drug will be metabolized by N-acetyltransferase 2 enzyme, and the metabolite will be excreted in kidneys. Of course, the resistance will be due to various factors like mutation of CATG, overexpression of INHA, and the development of efflux pumps. If we talk about the pharmacokinetics of isoniazid, it is 100% absorbed well. Isoniazid, as we already saw, it is metabolized by N-acetyltransferase type 2, and it has two distinct alleles. One is slow acetylator and another is fast acetylator. People having slow acetylators have around 3 hours as half-life, whereas fast acetylators have 1 hour as half-life for the isoniazid. Even though the half-life changes, the efficacy does not change much, but this will considerably change the ADR profile. Example, you can see this bimodal distribution of fast and slow acetylators, and you can see how the T half is increased in slow acetylators and is decreased in fast acetylators. The efficacy is measured as AUC by MIC. and INH is bactericidal. When we talk about ADRs, especially the slow acetylators, it causes liver injury and peripheral neuritis, which can be prevented by pyridoxine prophylaxis. So we saw that rifampin is an enzyme inducer, whereas isoniazid is an inhibitor of CYP2C19 and CYP3A. Okay, and it also a weak inhibitor of CYP2D6. So that will cause again various drug interactions, because most of the drugs are metabolized by these cytochrome enzymes only. The next drug is ethambutol. It inhibits arabinosyl transferase 3. Basically, it disrupts the transfer of arabinose into arabinogalactin. So this will eventually lead to disruption of cell wall. Of course, as expected, the resistance is due to this arabinosyl transferase gene mutation, EMB gene, and also due to efflux pumps. When we talk about the adverse drug reaction profile, pharmacokinetic profile of ethambutol, again it is absorbed well orally. It has a 2-compartment distribution with distribution half-life around 3 hours and elimination half-life around 9 hours. Mostly eliminated unaltered in the urine, so renal failure will require dosage reduction. The pharmacodynamic characteristics is measured by AUC by MIC for tuberculosis and as Cmax by MIC for MAC, Mycobacterium avium complex. When we talk about the adverse drug reactions for ethambutol, it is relatively safe, but sometimes it can cause neuronal toxicity, like it can cause optic neuritis, causing red-green color blindness, and children will be very children cannot perceive this color blindness properly, so we have to be extra cautious when we give it to children, and sometimes it can cause seizures also. And the last drug in the class of first line drugs in the management of tuberculosis is streptomycin, and we all know that it's an aminoglycoside. Okay, it inhibits the protein synthesis by disruption of the formation of initiation complex, okay, during translation. We all know that being an aminoglycoside, it is an injectable. It distributed only in the extracellular fluid, excreted unchanged in the kidneys, and it has its typical nephrological and cochlear toxicity. And mutation in RPSL and RRS gene will lead to the development of resistance to streptomycin. Okay, we have already saw about the toxicity, and because it's an aminoglycoside, it cannot be administered orally, so it has to be injected, and it will act only on extracellular mycobacterium. It cannot enter the macrophages, but it penetrates the CSF very well. So as already saw that aminoglycoside blocks the formation of initiation complex and thereby disrupt the polypeptide chain production. So when we talk about ethionamide, here we start with the second line drugs. It is very much related to isoniazid and blocks the synthesis of mycolic acid. We talk about fluoroquinolones, and these are the drugs administered orally. The most common drug used in the management of tuberculosis is moxifloxacin, whereas Indian guidelines suggest other drugs. I think it's levofloxacin. Okay, mechanism of action, of course, it either acts on DNA gyrase or DNA topoisomerase 4, thereby stabilizing the DNA enzyme complex. Okay, so thereby prevents the transcription. Adverse effects, it's a relatively safe drug, but it can cause cartilage damage. Otherwise, not no much ADR with fluoroquinolones. And of course, it is administered orally. Paraamino-salicylic acid similar to sulfonamides, which are antimetabolites. Okay. Then these are the two advances which you need to remember. The two newest drug in the management of tuberculosis, especially the drug-resistant tuberculosis. The first is the bedaquiline. It inhibits adenosine 5 triphosphate synthase in mycobacteria. Basically, yeah, it prevents the formation of ATP. So without ATP, which powers each and every activity inside the cell, without ATP, the mycobacteria will eventually perish. Okay, so because it acts on ATP, it can act on both dividing and non-dividing bacteria, and it is highly bactericidal. There is no cross resistance with other class of drugs used in the management of tuberculosis. We'll talk about the characteristics of the drug. The food actually enhances the absorption, metabolized by say 3A4, so it is prone to drug interactions, and half-life is in months. The next drug is delamanid. It inhibits the mycolic acid synthesis by interrupting the step between hydroxymycolate and ketomycolate, and it causes the direct poisoning of respiratory complex. It can also cause the direct poisoning of respiratory complex. It's administered orally. What to say? Again, it's metabolized by CYP3A4 and is subject to drug interaction similar to bedaquiline, and the half-life is around 30 years. So these are the drugs used in the management of tuberculosis. In the next class, we will see the steps in the pharmacotherapeutic management of tuberculosis, and also we will discuss the Indian guidelines. Thank you.